My name is Jiun Kong, and I work at Seoul National University Hospital in Korea. And I can see that we have only three speeches, which was originally four. So I think that I have some time to have some sufficient talk. So regarding TAVI, we all know that there's a grand expansion of the indications in TAVI. Usually it started for futile patients and then extremely high-risk patients, high surgical risk patients, high surgical risk patients, and then intermediate and then low-risk patients. So now in the current era, everybody is treating TAVI for, including extreme patients, but majorly the low-risk, young-aged patient. So this is the patient that we are treating right now. So this made the shift of what matters to change compared to the past. Usually we try to reduce mortality, we try to reduce stroke, but now the point that we care has shifted a little bit. This has now changed a lot more because younger patients are receiving TAVI. Younger patients are majority they are both low risk patients, but we have to keep in mind that low risk does not equal young age patients. So young age patients are super low risk patients, and these patients have a larger, different risk in the future. Even in the US, we can see that even patients under 65, almost half of the patients receive TAVI, which is a very different thing that we observed a decade ago. So regarding these patients, because these patients have a long life expectancy, this means that we will experience a lot of repeat interventions in the future, which means that there will be a lot of valve-in-valves or valve explants or additional surgeries that we do not have experience in the past era. So usually, as I said, in the extreme high risk, the high risk, the intermediate risk, we focused on patients over than 80 years old. We usually treated with tri-leaflet anatomy aortic stenosis. The activity of the patient was low. Therefore, we focused on mortality, stroke, quality of life, and pacemaker implantation rates. However, now we shift to the low-risk population, which are lower aged, and have a higher risk of any kind of concomitant coronary artery disease in the future. They are more bicuspid, and the activity is higher, which means that we should focus on hemodynamics, the valve durability, and any kind of issues such as coronary excess, which may be a fatal event in the future. So usually we were used to Kaplan-Meier curves like this. It was mortality plus disabling stroke. Very, very hard outcomes showing that a arm showed better outcomes compared to the other arm. However, nowadays, we are not using these kinds of Kaplan-Meier events. We are using different parameters to evaluate the efficacy of TAVI itself. So when we talk about lifetime management, as I said, because we're treating younger age patients, we should focus on how long a single valve can last. That is the valve durability. Also, we have to talk about the specific disease subsets, such as the bicuspid aortic valve patients. Also, in whom and how we can do further intervention, which includes PCI plus valve-in-valve procedures. Also, to minimize any kind of bioprosthetic valve deterioration, we should perform the best medical therapy, and currently the focus is on the best antithrombotic therapy in these patients that we treat. So I'll talk about these issues one by one. So regarding long-term valve durability, there's a lot of definitions, and currently we are using the hemodynamic valve deterioration or the bioprosthetic valve dysfunction, which includes pressure gradient increase in echocardiography, and also any kind of hypoattenuated leaflet thrombosis in CT images. So regarding the hemodynamics, we know that this is important. We think that this is important, but still we don't know whether this has any kind of impact in the valve function itself. In the past, in the surgical field, we know that any kind of hemodynamic valve deterioration, which means there's a pressure increase during the follow-up, is very closely related to mortality or any kind of reintervention in the valve, which means that this may be an indicator for any kind of valve failure. Also, in the early era, when we compare TAVI to surgery, we try to say that TAVI is better in hemodynamics compared to the surgical arm, showing that probably TAVI would be a better option in patients because it has a better hemodynamics. Recently, there was a long-term follow-up of the Notion trial, which was a trial that was performed quite long ago in low-risk patients. So because this was a study performed in low-risk patients, the number enrolled in this study was not that large. However, there is a long-term follow-up, again, because this was a low-risk study. We could see that the hemodynamics of TAVI is better compared to the surgical arm. However, when we try to transfer this to structural valve deterioration and clinical outcomes, there's a slight discrepancy that we can see. The structural valve deterioration was superior in the TAVI arm, showing that there's less structural valve deterioration. However, there's no difference in clinical outcomes. So probably the link that we thought that any kind of valve deterioration leads to clinical outcomes may not be that much true in the low-risk population that we have. When we apply the definition of bioprosthetic valve failure to this study, we could see that there's no difference between TAVI and surgery. So then whether TAVI is better than surgery may not be an issue that we can interpret by using the hemodynamics that we have. So the long-term valve durability, we try to apply the hemodynamics to long-term valve durability. However, if the hemodynamics does not link to clinical outcomes, the assessment of long-term valve durability is getting more difficult than we thought in the past. Also, we should keep in mind that there is a recent trial called the SMART trial. I suppose that a lot of you know about this trial, which compared supraannular valve versus balloon applied valve to small annulus patients. So the results showed that in regards of bioprosthetic valve dysfunction, that the supraannular valve was better compared to the balloon expandable valve, probably by a 1/4 of event rate. However, there was no difference in clinical outcomes, and this was extended to the 2 years follow-up recently, showing that there's no difference in clinical outcomes again. However, showing that bioprosthetic valve dysfunction may be inferior in the balloon expandable valve arm. So again, trying to interpret the patient by bioprosthetic valve dysfunction can be a surrogate marker of the valve function itself, but does not lead to any kind of clinical outcomes. So as we are clinicians treating the patient and our ultimate goal is to reduce the clinical outcomes, whether we should keep value in this valve prosthetic valve dysfunction definition, this gives us a fundamental question whether BVD is important or not when we evaluate the patient. So these are cases that we meet in the clinic. So this was a patient, an 80-year-old patient who received TAVI with a SAPIEN 3 20 millimeter valve, which is quite small in the TAVI field. And also during follow-up, we could see that the Vmax increased to 2.4 meter per second with a mean pressure gradient of 26 millimeter mercuries. So we could see that there was any kind of hypoattenuated leaflet thrombosis in the CT exam, and also we could see that there was a nicely movable leaflets in echocardiography. So in these kinds of cases, when there's probably insignificant asymptomatic elevation of the mean pressure gradient during follow-up, what does this mean in the clinical area? We still don't know what it means. We still don't know whether we should change the antithrombotics in these kinds of patients or whether it will be useful or not. So the next issue is commissure alignment. As we are treating more younger patients, more patients have or will have coronary artery disease. A lot of previous studies have shown that up to 80% of patients have coronary artery disease at the TAVI procedure. So these patients might have a recurrent event during the follow-up. So these are cases that we meet in the clinic. So this was a patient that had a significant stenosis in the RCA and was treated with PCI during follow-up. So we have to have a nicely engagement during the small struts of the valve that we implanted in the past. So when we talk about commissure alignment, as I showed you, the main issue that we do commissure alignment is coronary alignment. That is, we should match the coronary outside of the struts of the previous TAVI valve. However, when we talk about coronary alignment, commissure alignment, it's not just aligning the coronaries. It's maintaining the natural hemodynamics of the periosteal area, and this might be more important in making the natural hemodynamics as natural as we were born in the younger age patients that we treat. So in patients with severe commissure alignment, obviously we can see that further PCI will be very difficult if the valve is implanted like this. So if the valve is implanted like this, we should do additional methods to align the commissure, which is not that much easy in the current valves that we have right now. Of course, there are some techniques that we can twist the valve and make the commissure alignment more natural and making the left main ostium, the RCA ostium, far from the commissures of the bioprosthetic valve. And again, some valves in the future will be able to do a rotation event at the annulus to make the commissure alignment more easy. However, again, whether this is meaningful or why we are doing, is it commissure alignment or is it just coronary alignment, is another issue that we should keep in mind in the future. Some studies have compared the current valves that we use and whether there is a commissure alignment that is possible, whether it is manageable, whether it is modifiable, and showed that if we do any kind of aligned technique, that the commissure alignment, the coronary alignment will improve, whether compared to in those techniques that we do not do any kind of maneuvers to align the commissures. So the third issue is intervention for valve failure. As I said, there's a natural course of the bioprosthetic valve failure, which fails in about 10 to 15 years in the surgical arm. So this will be, there's a high chance that this will be very similar in the TAVI arm, showing that if the patient received TAVI in the age of 65, this patient might have a valve failure at the age of 75 to 85. So that means that we should perform a re-intervention. So in these cases, we should keep in mind that there is a manufacturer ID, there's a true ID, there are some valves that are fracturable, some surgical valves, as you can see in this arm, and when we go into the TAVI arm, we should get used to these all measurements, which shows that there's various heights, various lengths, various depths that we have in the TAVI valves that we currently use. Also, we should keep in mind how we did the first intervention, because all these numbers get different how deep we implant the valve in the initial procedure. Also, when there's some kind of difficulty, currently we are doing a lot of valve modification techniques such as basilica. However, these are not that much easy. There's a lot of hurdles in doing these kinds of procedures. So I think that it is very difficult to get the best outcomes in the valve-in-valve procedures that we do. So when we do a valve-in-valve procedure, what is additionally important is that we should try to avoid any kind of severe patient prosthesis mismatch in these kinds of patients, because there's a initial valve, there's a second valve, which makes the aortic annulus smaller and smaller. So there's a lot of issues that we can try to inhibit any kind of patient prosthesis mismatch by doing a lot of techniques. But again, these techniques are very difficult, and they might lead to mortality events, which makes us very cautious in doing these kinds of events. Next is the medical therapy to prevent bioprosthetic valve failure. As I told you, the antithrombotic therapy is very important after we do TAVI, because this can prevent valve thrombosis. This can prevent any kind of coronary artery disease event. This can manage AFib, concomitant AFib, and also this can optimize the long-term valve patient and also reduce any kind of stroke or TIE events in the patients. So when we talk about the valve itself, because AFib, stroke are not the valve, they are the patient. When we talk about the valve itself, we should talk about the optimal antithrombotics in regards of the valvular thrombosis. This is a very common event. However, the clinical implication, when this kind of valve thrombosis gets clinically important, it's very rare. So still we don't know whether these kinds of hypoattenuated leaflet thrombosis may lead to valve dysfunction or may lead to clinical events. So there's a lot of questions in these kinds of slides, so that makes the treatment more difficult. There has been a lot of trials that have tried to evaluate the best antithrombotics in these patients. However, the current guidelines show that if the patient has atrial fibrillation, the patient should go on with any kind of oral anticoagulants. If the patient does not have an indication of oral anticoagulant, the single antiplatelet therapy might be the best. So this is a very simple recommendation, but this is a recommendation that applies to those even without a TAVI valve. So whether we are talking about the TAVI valve itself, whether the TAVI itself has an exceptional antithrombotic strategy, still we don't know it. And also the current guidelines seem to just apply a very general recommendation, probably may not apply to very specific TAVI patients. The final issue is specific subsets, the bicuspid aortic valve. We know that the bicuspid aortic valve is very different from the tricuspid aortic valve, not only by the clinical presentation, but probably by other kinds of hemodynamics or probably genetic causes. So there are a lot of issues when we talk about the ascending aortic dilation plus bicuspid aortic valve, whether this is a nurture or whether this is a nature. So the reason that we talk about whether we should treat bicuspid aortic valves in TAVI is because there might be a future risk of aortic rupture if we do not treat the ascending aorta dilatation at the initial treatment. So to give this an answer, we did an analysis in our institute by analyzing the ascending aortic volume in tricuspid and bicuspid patients and doing a serial follow-up in the patients that we did TAVI in our center. So this was a comparison of about 280 tricuspid and 50 bicuspid aortic patients. We could see by the hemodynamics, after TAVI, both arms improved, while the baseline Vmax was more larger in the bicuspid aortic valve arm, which is quite natural, which is a quite usual finding that we see. Regarding the ascending aorta dilation in the bicuspid aortic valve, we could see that the ascending aorta volume, the zone of interest that we analyzed was 10, 10, and then 11. So there was almost no increase during the 5-year, this was a 5-year follow-up study, no increase in the 5-year follow-up study. However, in the tricuspid arm, we could see that the volume was 8, smaller than the bicuspid arm, obviously, and then 8.7 and then 8.9 with a very small increase. So unlike our expectations, probably doing TAVI in bicuspid does not aggravate or does not have any issues in the ascending aortic dilatation. So there might not be an issue in performing TAVI in bicuspid aortic valve just because there's a concomitant aortic valve dilatation. So this is a conclusion of my speech. As I said, TAVI is expanding over to low surgical risk and younger patients. This means that there's a paradigm shift of what matters, and this makes us that we should guarantee that we will do a better procedure to make the long-term outcomes more better. So the new focuses are on the hemodynamic evaluation, whether this is important, what is important, and also more accurate implantation, which includes commissural alignment, more delicate procedures to specific subsets, including bicuspid aortic valves, and finding the best treatment in these kinds of valves, which includes the role of antithrombotics. Thank you for your attention.